It really is a pleasure for me to be here, and I want to thank Randy for that introduction. He got most of it right, but like most things, Randy has a little bit of tendency to embellish and take poetic license, very much like he does on the golf course with the rules of golf, which is why over the last 2 holes he has to come up with ploys to try and get the better of me. In preparation for this talk, and for most talks in my entire career, I have presented facts, figures, all the way down to molecular biology, ultrastructural changes, the endothelial cell structure and function, etc. But for this talk, I decided to use no slides. It's certainly a step out of my comfort zone, but my wife says that finally I'm developing a personality. I really do appreciate the honor of serving as president of the Southwestern Surgical Congress this year. It has been an incredibly enjoyable time in this year of my presidency and in the almost 20 years I've been part of this organization. The organization itself, to me, has become almost a home. Based on my history, as Randy told you, I have been intricately involved in surgical education, and this Congress, unlike many others, is, I think, one of the better, and if not the best, in incorporating education for all constituents of surgery. That includes academic, community, rural, and the residents. And the interaction between or among all of those was evident last night at the reception between the residents, the faculty, etc. And I really appreciate this. I do wish to express my appreciation and thanks to a lot of members of this Congress who have helped me grow within the organization. Dr. Scott Peterson, Maria Allo, Ed Nelson, and Ernie Dunn were constant resources during my time as a member of the Council and the Executive Committee. I have thanks to Russ Postier. I always call him Russ Postier, but he says it's Postier. That's supposed to be French. And he was gave me a lot of information when I became president-elect. I have a special thanks, though, for one other individual in this organization, and that's Jim Edney. In my time with the Congress, Jim has put in a huge amount of time, and I think it is because of his effort that this organization is so successful. The college is also fortunate to have a group that manages for us, including Noni, Lowry, Jill, Denise, and the others, and they've made it this year much easier for me than I probably have made it for them with some of the demands on their time. Some of what I present today I hope will be provocative, but it's also with the intent to stimulate some meaningful discussion. In the 2 years in preparation for this presentation, I thought of numerous topics. I, like most presidents, reviewed X number of presidential addresses from many organizations. With my interest in trauma and critical care, I thought of the numerous scientific presentations. One of my pet interests is in fluid and electrolyte and acid-base balance, and I'm sure the residents that are in the audience are cringing when I even bring up these issues. I place proper emphasis on the detail in these areas because recent data has shown that 1 in 5 patients admitted to hospital will have fluid and electrolyte abnormalities that result in morbidity and sometimes even death. And this is a sobering issue when one considers the numbers of patients that we actually treat. There is, for example, a correlation between hyponatremia, particularly preoperative hyponatremia, and surgical morbidity and surgical mortality rate. The lower the sodium concentration, the higher the mortality rate. Some of the information in the textbooks regarding fluids, electrolytes, and body composition is outdated and incorrect based on newer research, perhaps contributing to some of these problems. Most recommendations for fluid and electrolytes in surgical patients are based on the classic 70-kilogram young male who doesn't exist in today's society. It's estimated that's less than 0.5% of the population. These young patients are also a minority of all patients that need surgery, yet it is this characterization that is the basis for all recommendations regarding fluid management, with very little consideration as to how to extrapolate to the other 99% of the population. Very little is also written in standard text regarding body composition, which is one of my pet interests, and the fluid and electrolyte disorders in the elderly. And now that I'm getting to that age, it becomes even more important for me. Other than from trauma, most patients in the surgical intensive care units are elderly, and even minor mismanagement of fluids in this age group can prolong ICU and hospital stays with increased morbidity and mortality rate. My perception in the 30 years that I've been doing critical care and trauma and general surgery is that a lot of these errors that occur in the elderly result in extended nursing care after discharge, and much of it might be preventable. How much of an improved quality of life and or cost saving would be realized if even half of these electrolyte disorders and their consequences could be prevented? Precise management and management of fluid and electrolyte disorders in the elderly will become even more important as the population becomes older. In the very near future, we will have almost 60 million elderly in the United States. I did also consider a presentation on surgery in the morbidly obese, which is now becoming, if not having become, the most prevalent operation in the country. Although some studies have extolled its virtues, recent work has questioned some of the long-term cost benefits attributed to the procedures. With respect to body composition in the obese, in contrast to previous knowledge, the obese have a substantial lower body percent weight as water as a percentage of their weight. When we extrapolate that with the residents, many times we'll find studies that actually show that in the morbidly obese, in contrast with the standard 60% in the young healthy male, as water as a percentage of weight, in the morbidly obese, it's closer sometimes to 35 or 40%. The blood volume in these individuals is also less. And for the residents in the audience, this is where I tell the residents, please question what you read and please question what I tell you. If you don't, everything in surgery becomes dogma. As an example, every textbook states that 7% of your weight is blood volume and 5% of your weight is plasma volume. And this has been true for the last 25 years in every textbook. Yet if you figure that out, that means your hematocrit is 29%, which doesn't make sense for the normal. In fact, the correct term is that 6% of your weight is blood volume and your plasma volume is closer to 3.5%. So it makes a difference with fluid resuscitation as well. If we use these terms to figure out the amount of fluid that's required for patients, we use two common formulas, the 150-20 rule that is more commonly used for pediatrics, and that's a daily amount, and the 4-2-1 rule, which is the hourly rate. Two things with respect to this. First, it doesn't apply to the elderly, and second, it doesn't apply to the morbidly obese. If you use either formula to treat the fluid and electrolytes in these individuals, they will develop what is termed fluid overload. They become edematous, they develop pulmonary edema, they may develop pleural effusions, etc. The problem with the term fluid overload is that it really is missed by, or it's a controversial. What I think is fluid overload and what Dr. Murayama might think and Dr. Smith might think are sometimes different, and they are dramatically different what the medical people and the surgical intensivists say. So my preference is, with the residents, is that they need to be more specific in what's going on. Just as an aside also, 30% of all the surgeons during their career will develop venous insufficiency. So for the residents in the audience, start using your support stockings early. What is fluid overload? I tell them, instead of saying that the patient is overloaded, that what you should say is that they have an increased total body water, they have increased extracellular fluid volume, but they may be hypovolemic, which is not uncommon in people after surgery, or if they have things like GI bleeding. But I'm not going to talk about these anymore. I was going to dedicate the presentation to these issues, but there were three things that changed my mind. The first was my ongoing concern regarding surgical manpower, and this is particularly in the community and rural areas where I've spent the last 23 years. I did practice in a small town for 3 years, and I was and am very aware of the problems with recruitment, retention, and availability of general surgeons in the small community and rural sites. The presentation I gave at the 2006 meeting in Hawaii was a reflection on my concern regarding rural manpower. When I became chair of the Department of Surgery at the University of North Dakota, and for a time as program director, I traveled throughout the states, actually visiting a lot of the sites where my former graduates practiced. And I went to almost half of their sites. And as a result, I really came to understand and believe that the experience required to prepare surgeons for community and rural sites are different than what is required for an urban practice, where multiple surgical specialties exist and competition can be significant. This difference, I don't think, is so much in what is taught, but the emphasis on what is taught. For example, in rural and small communities, endoscopy is a very prevalent part of the practice, yet in most urban practices, it is not. In small communities, they also need to be skilled in basic gynecology, including C-sections and hysterectomies. Urology, they need to do nephrectomies, cystoscopies. They manage simple orthopedic injuries and even some ENT procedures. All priorities for rural and community practice, not for urban practice. One of the studies that one of our residents did, Joel Harris, who's in the audience, with our current chairman, Dr. Sticka, was to look at the actual procedures done in the general practice of surgeons in North and South Dakota. And their breadth of practice was substantially different than what is commonly reflected in what is reported from the American Board of Surgery. The American boards report the numbers and types of procedures that are reported for recertification. What Joel and Bob Sticka did was to look at it and show that there are substantial differences. The unfortunate thing is that a lot of the discussion regarding training relates to the American College of, or an American Board of Surgery data, and I think that has to change. The second issue that changed my mind had to do with a book that Tom Russell, I believe, is in the audience or was here, and that is the book put out by the American College of Surgeons called A Century of Surgeons in Surgery. The chapter title was the second chapter, and it stated, "Who is a surgeon?" And it was tried to define who is a quality surgeon in the early 1900s. At that time, there were no specialist surgeons. I thought it was appropriate question for today in view of the increasing numbers of general surgical specialties that have developed and appear to be a major reason why general surgeons are not going into, or graduates are not going into surgery when they graduate. So who is the general surgeon today, and what is the need, if any, for a general surgeon in the future based on comments that I've heard recently? Multiple analyses by medical and government organizations in the 1980s predicted that by the year 2000, there would be a surplus of physicians, and most of us in the audience are aware of this. The Balanced Budget Act of 1997 fixed the funding for the numbers of residents in all of medicine and specifically in surgery. The problem is these reports could not predict what happened to the population, and over the last 2 decades, our country has grown by over 20 million, almost 25 million people per decade. Therefore, the concern that a shortage of physicians would occur really didn't surface until the mid-1990s. There was, unfortunately, at that time, a report by a person by the name of Schneider in Europe that was really misinterpreted. And it resulted in the proposal by many in this country that at least 50% of all physicians would need to be in primary care. And this led to the proliferation of all the information from politicians, medical organizations, and many universities that at least 50% of the graduates should go into primary care. As I said, that was a misinterpretation of that paper, but it was used and perhaps ignored for any number of political reasons. And I think that still exists. We're still looking at trying to produce 50% of all graduates going into primary care. What was not appreciated, or perhaps was ignored, I think, for any number of political reasons, was that all physicians aren't interchangeable. If you look at the people in the room who are general surgeons, specialist general surgeons, including vascular, endocrine, breast, colorectal, etc., we are not interchangeable. In certain practices, there are specific areas that you can and need to do certain procedures, but all of us can't do the same procedures, and yet the politicians continue to ignore this fact. Looking only at numbers of groups per 100,000 doesn't accurately reflect the different needs of the country and in each of the subspecialties. For example, I don't think a surgeon in New York or Boston has the same qualifications or requirements that are needed for the community area. And the manpower needs specifically are different. Although there has been a slight trend for a population shift of young people from the rural to the urban areas, and we've experienced that in the Dakotas as well, the problem is the elderly numbers are increasing. So in the rural areas and the smaller communities, the need for the general surgeon is actually increasing rather than decreasing. Since 1997, we have been basically graduating 1,000 per year, anywhere plus or minus 50. But in recent data from the American boards, and we are only now graduating 900 who graduate with general surgery. The others are plastic, colorectal, and pediatric. Of those 900, only about 200 are going into general surgery. In the past 25 years, there's a progressive decrease in the number of surgical graduates. Everybody's aware of this. The studies now show they went from 50%, the most recent data is 78%. What is not appreciated is that from 1996 to 2005, there was a 27% decrease in the number of urban surgeons and a 21% decrease in the number of rural surgeons related to the change in population. That is, the numbers of surgeons in each of the communities now needs to take care of more and more people. Current projections, and there are multiple in the literature now, suggest that there is indicate a shortage of general surgeons by the year 2030 of over 2,500. Each week, every 2 weeks, I get, as many of you probably do, emails from recruiting firms looking for general surgeons for certain positions. In the last month and a half in preparation for this talk, I've actually looked at it and counted them, and there is anywhere from 1,180 to 1,420 positions that are open for general surgery right now. So the graduates, if you wanted to go just in general surgery, you have any number of openings. The third and most important issue that changed my mind regarding this talk were comments related to the issue of fellowships. One of the candidates for our residency program, when I interviewed him, stated that he was looking for a training program that would give him a good foundation for entering a fellowship. He had been told on multiple previous interview sites that residents needed to complete a fellowship after their general surgery training. This comment really disturbed me, since the programs that I've been involved with over the last 30 years, including the one that Randy and I were with in Detroit, and the 23 years that I've spent at North Dakota, we train residents to become general surgeons without having to take a fellowship. Even more disturbing for me was when I went to some national meetings, and Dr. Green may be in the audience if he remembers, the speaker from Toronto stated that residents need to take a residency and a fellowship. There was no concept that this was a choice, it was an essential. And I felt that that was inappropriate. So my interpretation from these comments is that there are training programs in the country that have accepted that a general surgery residency is inadequate preparation for an independent practice. These comments, plus recent development of fellowships such as the ACS Transition to Practice program in general surgery, seem to support this attitude. It bothers me a lot that there seems to be an acceptance of the inadequate training, as pointed out by some of these people, rather than to correct the problem. ACGME requirements for a surgical residency state, and I quote, "The goal of a surgical residency program is to prepare the resident to function as a qualified practitioner of surgery at the advanced level of performance expected of a board-certified specialist." It doesn't say anything about a fellowship training to complete it. The ACGME also states, quote, "Supervision in the setting of graduate medical education has the goals of assuring each resident's development of the skills, knowledge, and attitudes required to enter the unsupervised practice of medicine and establishing a foundation for continued professional growth." Programs that state that general surgery is becoming obsolete, that residents need to get a fellowship training, are not acknowledging these guidelines from the ACGME. I believe that those programs that state that resident training is a prelude to a fellowship are failing in their requirements for the residents. In other words, it would be the residents, if the training is inappropriate, the program has failed. An alternative explanation might be that the program director may feel the resident is ready, but the resident does not feel they are ready. But is it not the responsibility of both to assure that the resident is ready to practice when graduating? And in this respect, the resident really needs to take some ownership of their education during their program. Unless corrections are made to address what I consider inadequate training programs, we are getting to a stage in surgical training where programs will have to declare that they only prepare residents for specialty training, and other programs that they prepare residents for independent general surgical practice. This would require a revision of ACGME guidelines, board requirements, and a host of other changes which I think we do not need to proceed with, nor should we. As noted before, in the past decades, there has been a rapid increase in the number of fellowships. Some of these are controlled by societies such as surgical oncology and vascular surgery, but until recently, most have been independent of any governing or accrediting body, such as the ACGME. As noted before, there's been a progressive increase in the number of residents taking fellowships, almost 80%. This may be one of the reasons that have led to the question from some surgical leaders, is the general surgeon becoming obsolete? Expectations, the question was asked of residents who answered the National Study of Expectations and Attitudes of Residents in Surgery survey in 2008, and some of the more recent grads may remember this. 27% of the 4,586 residents who answered the questionnaire answered, yes, general surgery is becoming obsolete. But when you evaluate the results further, it shows that 72% of residents in academic programs considered they were becoming general surgery was obsolete, but only 25% in community programs. The more senior residents in both types of programs did indicate a higher interest in fellowships, indicating there's a transition of interest into fellowships. Most residents in the survey who agreed the statement were single, from academic programs that had affiliated fellowship programs, and 38% of all of them were from the Northeast region. The problem with this is that, is there an influence with respect to the fellowship training on the residents? A Canadian study recently suggested that residents frequently will opt for fellowship training when they are exposed to a specialist in that surgical specialty, particularly during the senior levels of their residency. The majority of academic programs, particularly in the study I just quoted, have surgical specialists in leadership positions. Does this result in an unintentional influence on the general surgery residents, or is there, in some cases, intentional influence? I'm not the first one that has said this. What are the reasons for the substantial differences between academic and community-trained residents? Both types of programs have general surgical specialists that teach the residents, but I believe that the statement from programs indicating that general surgery training is becoming obsolete is in some ways a self-fulfilling prophecy. There are programs such as vascular surgery where the change in knowledge and technology has resulted in a different surgical specialty. This is not, however, true of minimally invasive surgery, which is one of the most common fellowships sought by graduating residents, and Dr. Murayama may disagree with me on this. At the start of the laparoscopic era, most academic programs did not have sufficiently trained faculty to provide the experience in minimally invasive surgery. Fellowships were developed outside of the academic environment, since it was the private sector that embraced endoscopy before the academics. I had personal experience with this when I left Detroit and went into practice in a small town in northern Minnesota. And the surgeon that I became partners with had done over 100 lap choles and 60 lap hysterectomies in that small town before the academic programs in Minnesota or any of the other local areas had even started them. So it really was the private sector that developed minimally invasive. I would suggest, however, that it must be now a very rare program, if it even exists, that does not have sufficiently trained faculty to provide adequate, minimally invasive training for general surgery residents. Why then are some residents, particularly in the academic program, still feeling that they do not get adequate training in minimally invasive training during their residency? The 80-hour work week might have something to do with it, and we use a lot of the 80-hour work week to justify problems. But in my view, the 80-hour work week is actually an opportunity to redevelop programs, to restructure programs, to try and improve the educational efficiency of these areas. Surgeons are trained to embrace and solve challenges, so is the 80-hour work rule really a reason for questioning the future of general surgery? Or is it an excuse for the statement? Fellowships by general surgery, by ACGME standards, should not interfere with general surgery resident training. Yet in a recent meta-analysis evaluating the impact of fellowships on general surgery, only one article authored by Dr. Kathari, who's in the audience, indicated a positive effect on residents. All the others indicated either a neutral effect or, more commonly, a negative effect on resident experience. That is, the fellowships were taking away the experience of the senior residents. Have academic programs really evolved such that fellowships essentially now drive the experience of the general surgery residents? That is, they limit the experience so that residents are directed into fellowships. I have multiple questions regarding fellowships. Some of these perhaps are not answerable at the time. Why do general surgery residents go into fellowships? And I'll approach that in a minute. What is the perceived value of a fellowship? Is there a need to go into a fellowship? And I talked with some of the residents last night about that. Are fellowships in general surgery really siphoning off so many graduates that general surgery will become obsolete? I think they are siphoning it off, but I don't think at the present time, in spite of some people, that general surgery is becoming obsolete. If this is true, however, and in view of the need for general surgery in a large part of the population that is not urban, how do we support and improve the training of the general surgeons such that they do not need or wish to obtain fellowship training? So the question, why do general surgery residents go into fellowships? In my case, I actually began with it was intellectual curiosity. which began in my third year of medical school. A number of my questions regarding, I even started fluid and electrolytes then, Randy, the questions just weren't answered. So during my residency, I completed a PhD in experimental surgery, correct, but it was on the ultrastructural response to hemorrhagic shock, and that's where I really started with respect to my interest in the minutiae, if Randy sort of implied. The interest in shock resulted in my fellowship in trauma and critical care at Wayne State. The process for obtaining a fellowship was a lot different than today. The dean of our medical school, who was past chairman of the Department of Surgery and past president of the American College, called me one day and informed me in mid-December, the year I took my Canadian boards. By the way, I do speak English, so I hope it's not confusing Randy with lack of Americanisms. But he called me and stated, quote, "I hear you are interested in a trauma fellowship. Dr. Alexander Walt is expecting you in Detroit in 2 weeks for the fellowship." And that was my match. 2 weeks later, I was in Detroit. Increased surgical knowledge and new skills needed to use developing technology foster a desire to embrace the new technology and become more competitive. This applies to a lot of the stuff, including note surgery, etc., and the area of robotic surgery. But with few exceptions, I would question whether the robotic surgery is really being driven by industry rather than by need. It is certainly, in many cases, far more expensive than traditional surgery, and we need to take a much closer look at that. There are perceived financial incentives to have special certificates, but if you look into this closely, the difference between a fellowship and not taking a fellowship, particularly in MIS, if you project it out, it takes somewhere between up to 15 years to recapture the financial difference if you took a fellowship versus just going directly into general surgery. So the residents who are looking at that might take a much closer look. Some residents take fellowships because of a better lifestyle, and that's understandable. There seems to be much more common, at least in the study I presented earlier, that they are primarily residents with children, particularly women with children, that fellowships that do not include night or weekend call are the ones that the residents are going into. And for family issues, I think that is understandable, particularly with the current generation that looks at lifestyle far more than we ever did. Residents also enter a fellowship that holds a very specific interest, as it did for me. And last night when I was at the reception, there are residents who really have a passion for going into trauma surgery or one of the other colorectal, and that is truly understandable. But I also believe that there are certain procedures that are best performed by the general surgical specialist in those areas. This would include, for example, in vascular disease. Endoluminal stenting has changed vascular significantly, but more simple problems such as a patient coming with an acute embolic problem in their extremities should and can be taken care of by a well-trained vascular surgeon. You don't need to call a vascular surgeon to take care of that. In the area of oncology, yes, I believe that the oncologist should do the difficult procedures, the Whipples, the esophagectomies, etc., but most general surgeons can take care of the routine colectomies, etc. They don't need the special training. In fact, I believe at the recent surgical oncology meeting, which I have a report of but did not attend, there was a presentation that stated that 70% of all cancer surgery is still done by general surgeons. But only 308 counties in the country have surgical oncologists. We cannot train enough specialists to cover every county in the country. It just doesn't, it isn't practical. My belief is a well-trained general surgeon can perform most of the procedures that are done currently by the surgical specialists, and only the most complex should be done by those specialists. Some residents perceive that fellowship training might reduce the risk of a malpractice suit. However, the current data would fail to support this perception. If you think you're going into a X fellowship to hopefully reduce your risk, it's probably not going to occur. Successful defense of the lawsuit is based on numerous considerations, and a fellowship training may, or more frequently, may not be the reason for a successful defense. I am sure that there are many more reasons that residents could talk about, but I want to emphasize that it should be a resident's choice whether to or not to pursue a fellowship, not a necessity because the training has been inadequate. How will our patients be served in the future with respect to surgical needs other than everyone becoming fellowship trained? For now, there are not enough fellowships in the country to accommodate all residents, and I don't think there should be. Some predict that as the population grows, particularly the elderly, the fellowship-trained surgeons will become so busy with respect to their specialty work that 25% of their practice will revert back to general surgery or even more. This, coupled with the increased need of the population, particularly the elderly, I think speaks very positively for the general surgeon. My answer to the question, is the general surgeon becoming obsolete, is an emphatic no. Those who state this either truly believe that it is becoming obsolete or they are making excuses for their training programs. Not only is the general surgeon not becoming obsolete, I believe we need to make every effort to assure broad-based general surgery training in the future. General surgery is the foundation of every general surgical specialty. The Surgical Council on Resident Education, known as SCORE, developed by, I believe, the APDS and the college, is a reflection of the need to strengthen general surgery training, and I think that's very appropriate. There will be a need for broad-based general surgeon in the future. Over 100 million people right now in this country need a general surgeon, not a specialist surgeon. In the next 2 to 3 decades, it's expected that the population will expand by 30 million per decade. With the current numbers of surgeons that are being graduated, we haven't a hope of keeping up with that. Just as an aside, and in my experience, a number of specialty societies have a tendency to criticize the general surgeon in areas that they are doing inappropriate surgery. And we need to look at those procedures that should be done and can be done in communities and should be done by specialty surgeons and by general surgeons. That needs to be much more important. The other thing we need to look at is outcomes. In all the talks today and in almost all the literature that we look at, it's always morbidity and mortality rate. It is very unusual to see a paper that looks at the patient's perspective, which is quality of life. And I'll give you an example from my personal experience. We were trained to do hand and basic orthopedics, etc. And when I was in practice in the past, I would take care of hand injuries. So if a patient came in with a digital injury or an amputation of one of the digits, I would offer to send that patient to a hand surgeon, and after explaining what would happen, the patient would say, "Sew it up, I just need to get back to work." Yet when you take that to the hand specialist and that patient has a slightly curled nail or a slightly deformed tip, etc., to them that's an inadequate procedure. To the patient, that was more than adequate and practical. We need to look at the outcomes from the patient perspective. Another example is in our resident a number of years ago looked at the response or the attitudes of women having surgery for breast cancer. And the standard of care at that time was not what a lot of them chose. To them, it was a simple mastectomy. I need to get back to the farm. I can't take the time to travel 90 miles to have my radiation therapy. So from the Breast Cancer Specialty Society, that's inadequate care. From the patient, it was practical care. And we need to look at those differences sometimes and not necessarily criticize. Specialty societies' guidelines should be just that. They should not be absolutes. They should be guidelines. Who will provide surgical care for the patients in the future? I believe the foundation for care is and will continue to be the well-trained general surgeon, particularly for the community and rural areas. But there must be a change to future resident education. General surgery residents need to closely evaluate how they are training residents and to what end. If a residency feels that they cannot train our general surgery residents to practice without advancing to fellowship training, then they should so declare to the applicants, as I indicated early. Resident training programs need to comply with the minimal requirements for training, but be allowed more flexibility in their training schedule. If a program can achieve the desired goal of training a resident to become a successful surgeon, do the specific rotations and sequence of rotations really matter? If you give residencies guidelines and goals, and they meet all those goals, does it really matter how they get there? Some community programs provide laparoscopic surgery and advanced laparoscopic surgery sometimes, but usually at least in the first 2 years, and advanced laparoscopic procedures in the senior years. The residents feel comfortable with the skills development to go into practice and do the minimally invasive surgery. Why can't the others? What are the true essentials for general surgery residency training? I would hope that in the near future that advancement in residency is based on performance, not on arbitrary years. I know it's been discussed in the past. And in my experience, I have seen residents who, with their knowledge and skills, could easily pass their boards and go into practice after 4 years, not 5 years. Would this be a problem logistically? Yeah, probably. But we need to look at all possibilities and various ways of changing the residencies to meet the needs and get more people going into general surgery. What is the need, for example, this is a pet peeve of mine, what is the need for a transplant rotation? Most general surgeons really have very minimal experience with transplant, and it has, my feeling is, a lot of it's just to serve the service requirements of the transplant programs. In surgical evidence, there still seems to be an emphasis on lectures, journal club formats, etc. Yet most of these methods have been shown to have little effect on the retention of information. A simple lecture, the retention rate of the information that decays so rapidly that most of the time the retention of information is 10% at 6 weeks. Why does the ACGME continue to require programs to have a lecture schedule, a form of didactic program? It doesn't make sense. In the Canadian study, there was a Canadian study that looked at also, and they have a very similar program to here. What is the value of a journal club? Journal clubs for residents were at the bottom of the list. And yet so many programs still utilize that. I think that there are so many new changes in modern educational technology and knowledge. We need to incorporate this in faculty development. Most faculty teach as they were taught. And quite honestly, most of them don't do a very good job of teaching. The residencies must be allowed the latitude to change the rotations. You don't need a rotation on ex-service. In our program, for example, the residents, while they're on the general surgery service, in one of our hospitals can actually scrub with an ENT surgeon, a nephrologist, a plastic surgeon, while they're still on the general surgery service. They still get their experience. They don't need a specific rotation. I know this is not practical for everybody, but we need to develop designs and latitude and programs that would make the training much easier. There also needs to be a substantial increase in resident training positions. And this has been recommended for over a decade, but there's little result. We've had multiple discussions and recommendations for almost 20 years, and this is, to paraphrase Shakespeare, all sound and fury signifying nothing. There has not been much political support for this due to the inability, as we know, Senate and Congress to agree on anything, let alone funding. There has been an attitude by some in politics that by restricting numbers of physicians, costs will be reduced. That was an experiment in Canada that failed miserably, and they have had to rapidly increase the numbers of graduates from their programs in order to meet the needs of the country. I have no idea why we're trying to repeat the same experiment here. There is some hope, however. In the last week actually, there have been two bills introduced in Congress, one in the Senate and one in the House. And in the Senate bill, if they can agree to it, there will be an increase in the number of resident positions of 3,000 per year for the next 5 years. That's 15,000 more residency positions. In the bill, if you want to read it, and I did, there is a reference to a study done by the Health, Human Resources and Administration of 2008, where they outlined specifically where these residents are going to go in primary care and specialty care. I spent the last week and a half going through the various departments in the government trying to find that report. I couldn't find it. So either it is buried somewhere or it doesn't even exist. The majority of these positions, however, if they really come to pass, and I really hope they do, I think we need to dedicate at least half of these to surgical training and specialty training. And this is, I think, where the American College of Surgeons and other surgical organizations really will serve us well. They need to really lobby to make sure a lot of these positions go to the specialty training and surgery and not just into primary care. I do think that the majority of the surgical positions that may be available should be allocated to programs that train a surgeon to become a general surgeon without going into a practice, a fellowship. This is going to be difficult because we also need to define, as I mentioned earlier, how many general surgeons do we need specifically and for what regions of the country, what type of specialists do we need, and what type of procedures can and should they do. I think there's work by the college, and particularly work by George Sheldon and his group, where they are already starting to look at this. If we do get these positions, we also need medical students to be interested enough to fulfill the positions. I know we've addressed this with, I think I counted over 40 papers that I reviewed briefly, and there are more than that looking at this issue. For the residents in the audience, how you interact with the medical students while they are on your rotation has a major effect on their decisions to proceed with a surgical career. In a most recent study by the AAMC, which was just published a couple weeks ago, the two primary issues that medical students use to go into a specialty practice were primarily the interest as a personal fit for them, and also a mentoring of the people they work with, which includes residents. So you, as residents, have a significant impact on any medical students going into a surgical practice. In my career, I felt that 80 to 90% of all surgery is exciting, stimulating, enjoyable. Many of us, unfortunately, spend the other 10 to 20%, which is the negative. And we need to stop emphasizing the negatives to our growing colleagues. We need to emphasize the enjoyment that we get from surgery. The most recent review of medical student debt indicates from the AAMC that it is now 160,000. Of that, only 10% comes from undergraduate education. We need to find ways in order to reduce that debt in medical students in order to get more to go into all of medicine, but specifically into surgery. Why do we not, for example, have students go into medical schools after 2 years of training rather than requiring 4, 5, or 6? It makes no sense. There are numbers of programs in this country and other parts of the Western world where that in fact does happen. That would shorten the training time dramatically. And the fourth year of medical school is essentially a waste of time. We need to get those students into a type of training program where the last 3 to 6 months can be used as part of their residency training program. Now, word of caution in this. Everybody is trying to go into the boot camp concept in order to get the medical students prepared for surgery. But studies have shown that if you teach someone a specific skill, such as simple knot tying or FLS program, chest tube insertion, etc., and they fail to utilize that on a regular basis, the skill development is rapid enough that within 2 weeks, most of those are back to basics. So I am really questioning whether or not the boot camp concept will really be valuable for us in the future. But I do think that medical schools need to look at changing the requirement. The Curriculum Committee of the Association of Surgical Education, which I am on, I believe is working on how to incorporate a specific medical student curriculum for surgery into the entire year of, or the 4 years of training, so that when they do come to us in residency, they are far better trained than they are at the present time. We also need to address attrition and burnout rates in students, residents, and practicing surgeons so that we can actually keep more of us in the manpower area. 10% of medical students, 15% of residents, and up to 40% of surgeons have signs of burnout or depression. How many in these groups are classed as fatigue? How many feel fatigue from night call? But it might be other problems, such as sleep disorders. We now know that up to 20% of people have one form of sleep disorder, including sleep apnea. Are we going to have to start looking at our overly tired residents? We see residents at rounds that are falling asleep, etc. Is that really because they're fatigued, or do they have a problem with something like sleep disorder? We need to look at all of these to become more proactive in identifying and helping those who have these problems. In summary, I feel that the well-trained general surgery is not becoming obsolete and must not become obsolete. Comments otherwise regarding the obsolescence of general surgery, I believe, are the minority and are self-serving. We must critically assess all training programs and assure that they really are training residents to enter a successful practice, not just train them in preparation for a fellowship. General surgery, to me, has always been an exciting, intellectually stimulating, and satisfying profession. Let us continue to evaluate and correct the negatives in our training programs and enhance the positive. Residents, again, when graduating, should not be expected to complete a fellowship. They should be given a choice. We surgeons are noted for leadership. We are innovative, embrace challenges, and provide solutions, and we put our patients first. We should be able to solve the issues confronting general surgical education and the future of the general surgeon with respectful collegial dialogue. I would like to close by thanking those who have made my surgical career so satisfying. My surgeon mentors in my residency, those in my academic and private practice, the colleagues that I have developed over my years of education, such as Randy, and the medical students, and most importantly, the residents, my past, present, and future residents. You have made my teaching career what has been so satisfying. And to me, in my academic, teaching surgery, teaching critical care is what has made life in this profession as a general surgeon, in spite of my fellowship, so enjoyable. In many ways, the residents are the teacher's legacy. Last, and most important, I want to thank my wife. In spite of appearances to the contrary, when I was working the very long hours, she has always been the #1 love of my life, and I thank her for patience, endurance, support for my career decisions, and her love. And I thank you very much for your attention.